I also direct a WHO collaborating center for training and policy on access to pain relief. It's based in Trivandrum in Kerala, but as a pan-India agenda. I'm very glad to have this opportunity to talk to you, and I have very important things to talk to you. If you notice the title, it says anesthesiology and person-centered care. Well, you might wonder what else could it be. Look, medical education, medical training, and medical practice are ordinarily directorate, diagnosis, and cure of diseases. True, maybe also a little bit of prevention, but it is still focused on diseases. We anesthetists are part of that system which focuses on disease. And one of you may be my anesthesiologist. Thank you for taking care of my body. Thank you for taking care of my organ functions. But in the process, I hope you will also remember that I am a human being with emotions, with fears, anxiety, worries about some things that may be totally independent, craving for a human touch from my family. All these also would be happening to me. You are an anesthetist, but whether it's an anesthetist, a neuro-ophthalmologist, or a cardiac surgeon, we are still doctors. and the doctor has a duty to mitigate some suffering, and our duty is to cure sometimes, to relieve often, and to comfort always, and that you have heard, but the ICMR adds a sentence there. There is no exception to this principle. We have to mitigate suffering. So when I am on that table, I hope you will remember not only to keep my organs intact, but also to see whether I am suffering. If I am to I am your anesthetist. I am going to take care of you tomorrow or now. I will look after you. The fact that a human being cares for me will decrease my catecholamine levels. You ordinarily would use so many medications to reduce the catecholamine response to various procedures. But more than any other medications, what will work best is to know that you care for me. And most of us have not been is there any one of you who stops worrying because someone says, don't worry? I know the answer, not one. You don't deliberately worry. When somebody is saying, be calm, you don't become calm. You become calm when I know that you are caring for you. And when, suppose I say, I am afraid of not waking up after surgery. And then you reassure me, no, we are going to operative or post-operative. It needs to be relieved because pain is suffering. Now, I do find that a proportion of patients sent for pre-anesthetic check have not been given enough analgesics. They continue in pain. Hey, what's happening to their blood pressure now? What's happening to their heart rate? What's happening to their catecholamine levels? You have a ready-made potential catastrophe on your hands. And you prescribe, what do you use? Lorazepam or do you use something like alprazolam? Whatever you use. If somebody is in severe spasm, the same muscle spasm which causes a reflex withdrawal of the limb on acute pain causes a sustained muscular compression, muscular contraction, which is why following an upper abdominal surgery or a chest surgery, you have a higher extent of lower lobe collapse. That happens because there is regional muscle spasm. The regional hypoventilation of the lungs. The same thing can cause muscle pains in various sites. On the one side are the nociceptors or nerve endings which sensitize pain. The black and red things that you see here. And when it is stimulated by a needle, by a knife, by a chemical like prostaglandins or kinins or substance P or many other things, then an electrical impulse is generated in the nociceptor, which passes across the peripheral nerve and reaches the dorsal horn of the spinal cord. The impulses are modified at the dorsal horn of the spinal cord for onward transmission to the brain, to the thalamus. So each one of them senses the pain. More and more impulses are sent to the dorsal horn. And with time, if the pain is unrelieved, the self-perpetuation of pain increases. Now, the recruitment is not only at the level of the nociceptors, it's also at the level of the spinal cord. Adjacent spinal segments get recruited, which is why the person with the fractures today says my pain is here, and day after tomorrow says my pain is all over the chest. It gets recruited so much so that the whole body can be in pain in some very painful conditions. Those of you who are in the field of pain management would know NMDA. NMDA is involved in the process of central sensitization. Okay, so if I may go back on slide, remember we said that self-perpetuation of pain may occur because of skeletal muscle spasm, vasoconstriction and ischemia, recruitment of peripheral nociceptors, recruitment of adjacent spinal segments, sensitization of the periphery, of the nociceptors, and sensitization of the dorsal horn cell or the brain. Okay, let us move on. Why did I mention all this? We have to remember this when we are planning management. Sensitization of the nociceptor by inhibiting prostaglandins. Now, they all cause some side effects. Of course, you know that gastric irritation. We have to remember this. Every time we use a NSAID orally, parenterally, anything, we have to protect the patient with a gastroprotectant. A proton pump inhibitor is supposed to be better than an H2 blocker for this, but some protection is essential. Even more importantly, this is not ordinarily given due importance. Cause bleeding, but if there is any bleeding tendency, it's likely to be worsened. And in presence of bleeding tendency, because it inhibits platelet adhesion, it's better avoided. You can think of other side effects, like the allergic reactions. Or the hepatic dysfunction, which is there only with aspirin or nimesulide, which is not used anymore. But otherwise, ordinarily they do not damage the kidney, liver. So I would like you to remember these three things. Before you swallow a tablet of NSAID, or before you give it to your grandparent for the osteoarthritis, or before you use it myocardial infarction and stroke. Because it was not only not decreasing platelet adhesion, it was actually promoting platelet adhesion. Aggregation. Therefore, COX-2 selective drugs are known to increase cerebral and cardiac events. But this study found that diclofenac was as much likely to cause it as rofecoxib. I know it is one of the commonest drugs used. But think again. After we saw that study in our unit, we switched to examples. If your child has a colicky abdominal pain, what do you give? Dicyclamine or hyoscine butyl bromide? Antispasmodics. If there is a neuropathic pain, what do you use? A tricyclic antidepressant or an anticonvulsant. They are not basically painkillers, but in that context, they are the best drugs. Those are adjuvants. So that is step one. If you see this ladder, step 2 and 3 have only one more medicine added. That's an opioid. But I'll just mention that they are among the safest medicines. Once you have seen how they are used, you will understand it. You have to see it. Our medical education has not included it, so you will have to actually see how it's being done. The dose is exactly what is required to treat the pain, which may be as small as oral 2.5 milligram of morphine for hourly to 400 milligram or more for hourly. Depending on the degree of pain, the dose will have to be titrated. Uh, of course, if you are not able to swallow, it may have to be given rectally or parenterally. Constipation. Constipation is easily treated if you know what to do. From day one, adequate dose of laxatives will have to be given. And the dose of laxative may have to be stepped up. It has to be a stimulant laxative or an osmotic laxative. Stimulant laxative like bisacodyl or osmotic laxative like lactose, which is much more expensive. So one of these medicines would be the right choice. And if you use that, the vast majority of patients can live with adequate pain relief. Only about 2% of the needy have access to step 3 opioids in our country. Because they are not very, unless they are anesthetists, they are not familiar with NMDA antagonists. You are. Therefore, we need to learn a little about NMDA blockade. When central sensitization has occurred, which is also called the wind-up phenomenon, because it is like winding up a spring. Ketamine burst therapy And here is the starting with the 100 milligram dose, increasing up to 500 milligram depending on how much is tolerated. Any potential problems apart from dysphoria? At this very small dose, the increase in heart rate or blood pressure is unlikely to be significant. Dysphoria is a concern, granted, so we have to be careful. But recently, two other adverse effects of ketamine have come to light. One is hepatotoxicity. When we give ketamine over several days, it is possible day. Because if you continue it, you may end up with a situation where the patient may have to live with burning micturition for the rest of his life. Therefore, when you start a ketamine burst therapy or oral ketamine therapy, prolonged, always ask the patient every day, do you have burning micturition? And if he says yes, stop. So whatever I said was mostly related to either acute pain to have a serious illness. Nobody escapes. 90% of us goes through a prolonged illness before we die. It may more likely to happen in old age, but it can happen at any time. We need to find out why she is not taking the medicine. Her suffering, you and I have to remember, is not only the physical pain, it is the social and financial implication. It is the emotional burden, depression, anxiety, and 100 other things. And it's also the spiritual issue like, God, why did you desert me? Or, why am I alive? My life is of no value. I wish I were dead. All these are things that family know that the family members suffer as much as the patient does sometimes. We have a responsibility to reduce that. That is treatment of physical, social, mental, and so palliative care involves treatment of this total pain, the conglomeration of all these social, physical, emotional, and spiritual. So you assess, give adequate information to the patient, and manage these problems in partnership. The patient and the family are not your adversaries, they are your allies. The family may be arguing with you, but remember that they care for the patient more than you. The doctor's visit. And more than 300 non-government organizations in Kerala is involved in this. It is doable, and if you give up a little bit of your time, maybe your practice will come down by 1/5, but your self-satisfaction. Please take a note of this email ID, education@palimindia.org. We'd be more than happy to work with you. And to make sure that over 12 weeks, a session of 1.5 hours each, every graduate.
Good evening, respected members of Indian Institute of Anesthesiologists